Good afternoon. Zümrüt and I will present you our study, which focuses on moral motivation regarding predictive biomarker testing and preclinical diagnosis of Alzheimer's disease among affected persons in Germany and Israel. This study was conducted as a part of our German-Israeli project led by Perla Werner and Silke Schicktanz, and I will start our presentation and Zümrüt will continue. To begin with, I would like to raise a question. Would you like to have a test that predicts your likelihood of developing Alzheimer's disease in the next 10 years? So this question, still for many hypothetical, may become soon real. Recent advancement in predictive medicine and biological markers debatably promise to identify persons at risk for development of late-onset Alzheimer's disease by detecting the physiological changes at the earliest stages of the disease, namely pre-symptomatic or preclinical stage. Various researchers and companies worldwide have announced in the last 2 years that they have developed a cheap, non-invasive test, such as blood test, for the prediction of Alzheimer's disease. Apart from such a blood test, various biomarkers are still under examination and validation to predict the onset and course of the disease. Also, their use is still limited to the research context and not recommended in clinical context. The biomarkers are making their way into clinical practice. In addition, the large prevalence of dementia, together with the popularization of the topic in the media, the literature, and the movies, increases public interest, so it is becoming more likely that concerned individuals ask practitioners for testing, even if they have to pay out of their pocket. In general, the aim of this study was to understand and discuss the ethical and social challenges raised by new technologies and strategies to detect Alzheimer's disease in its very early and pre-symptomatic stage, to explore empirically it and to identify affected persons' attitudes towards dementia risk information and to illuminate their counseling needs. We thought it is crucial to consider public involvement, not only experts' opinions, and to identify the needs, expectations, and preferences of those affected directly or indirectly. In addition, we aimed to examine whether the differences in attitudes towards AD testing vary on a cultural level. More specifically, we focused on individuals' moral motivation for justifying why they're either or against predictive testing and early diagnosis. So in this presentation, we are going to present you our submitted paper, which is under review now. In this study, we used qualitative research methods. 3 groups of affected persons participated: people with mild neurocognitive disorder, their relatives, and family caregivers of people with dementia. We conducted focus groups and face-to-face semi-structured interviews with 44 German participants and 44 Israeli participants, to explore their attitudes towards prediction and early diagnosis of AD. Focus groups and face-to-face interviews were conducted according to semi-structured interview guideline. The guideline was developed jointly by the research teams in both countries in English and later translated into German and Hebrew. Our interview guidelines structured to focus on participants' experience as assessments of prediction and early diagnosis of dementia, assessments of situation in which predictive results were disclosed, the impact of this information on individuals and family life, and assessments of advance directive for future care. The analysis included several recommended steps for qualitative thematic content analysis. We did inductive coding in addition to deductive coding. In our analysis, we focused on participants' attitudes towards early diagnosis and prediction of dementia, and we investigated the extent to which of their arguments can be associated with moral attitudes. We identified 4 ethical categories structuring participants' moral motivation, to which participants in all stakeholder groups in both countries implicitly referred. So this is the matrix, which consists from 4 ethical categories structuring moral motivation: beneficence, future-oriented responsibility, self-determination, and vision of a good life. The first one is beneficence. Beneficence of an action includes assessments of benefits such as cost avoidance, risk reduction, improvements in well-being, and risk and cost. All of those were mentioned by study participants. The second one is future-oriented responsibility. Responsibility generally refers to making judgments about whether an individual can be held accountable for his or her behavior, actions, or their outcomes in relation to a moral object. It includes a time dimension. Retrospective responsibility means being responsible for some past actions, and prospective responsibility includes hypothetical outcomes regarding future events in the short or long term. The third category is self-determination, which stands for being autonomous in one's decisions by exercising personal control or having one's wishes honored when one is incapacitated. And the last one is the vision of a good life. It refers to individual perspective on what enhances life quality and how one should live his life. One vision of a good life is related to one's sense of self, one's identity, because identity is defined by what is important to an individual, what is central to the personal well-being, and what constitutes the person's notion of a full life well lived.
Thank you, Natalie. I will now continue with presenting our findings that are shared among the German and Israeli participants in our study. Participants in both countries were evenly split in their positions for and against predictive testing. In both countries, participants in all stakeholder groups mentioned potential long-term benefits of prospective risk assessment. These include starting early with medication, having a healthy diet, and cognitive training. Here is an example from our study. There is no cure, but there are things, medications, that can slow the progress down. In contrast, some questioned the utility of prospective risk information by noting lack of an effective treatment and expressed doubts regarding the credibility of predictive testing. If there is nothing you can do and I simply rush towards such a disease, then I, of course, would prefer not to know anything about it. We identified three senses of responsibility. Some participants in both countries emphasized the importance of considering concrete options for care and organizing financial issues to avoid burdening family members. I have a son. I do not want to burden him. I want to prepare things, to set aside funds, to prepare all kinds of things. Some participants expressed an expectation that the family is morally obligated to take care of a family member in an advanced stage of dementia. This attitude was tied to trust in one's family and the perception that the family can make good decisions. This was emphasized more by the Israeli participants. I think my children are so devoted that they know exactly what to do. Let's say if something happens to me, I trust them. They trust me now, I will trust them later. Some participants in both countries considered risk information and an early diagnosis as an opportunity to take responsibility for their own health. I think it was good that I had the test, because I think that everyone should do something for her health or illness. For many participants, dementia was understood as a disease that would result in a diminished capacity for decision-making and loss of memory. Many expressed a wish to make and carry out their own life decisions concerning future care, including advanced directives. This was emphasized more intensely by German participants. Here is an example from our study. For me, self-rule or self-determination is the highest good of an individual, and nobody has the right to revise the decision that was made out of free will. Some German participants saw early detection as an opportunity to plan suicide. Among Israeli participants, only a few in the directly affected persons group made this connection. If you indeed have the probability, you can think more clearly about it with a certain distance. To organize things, if there's a pill that can end one's life immediately, At least I have the option to think about it. Participants' expectation of the severity of symptoms affected their desire to obtain risk information. Some participants in the family caregiver and relatives groups in both countries believed that knowing their dementia risk would lower their quality of life. As everything I haven't got, which I am diagnosed with as possible, or let me say that I might fall ill with, that's a strain for me. In contrast, few participants in the family caregiver and relatives groups in both countries held that risk information or early diagnosis could help to improve one's life. If I know it, predictive information, great, I will plan, enjoy life, travel, I will enjoy it and seize it till the end. Israeli participants often referred to relevance of one's personality to explain one's position on dementia prediction. Here is an example. Here the individual's personality really enters the picture. Someone might fight it, but if she is the type who tends to depression, it is awful. In the existing studies, generally more positive attitudes towards predictive testing or early diagnosis were observed, whereas our study presented a more mixed picture. This could be the effect of the sampling strategy we used. We chose our participants very broadly via memory clinics, patient advocacy groups, and public advertisements. This might have led to differences in public opinion and might be interesting for further studies. We found that predictive testing and early diagnosis of dementia were assessed positively by some participants when perceived as providing an opportunity to plan later life, make future decisions irrespective of the limited prevention and treatment options. Our findings demonstrate the spectrum of moral motivation, including not only aspects of personal utility, but also ideas of responsibility between individuals and the family, the desire for self-determination and notions of a good life, which are formative for one's ideas about utility. Our study reveals skepticism about the predictive value of testing. When persons understand that predictive test validity is low, their interest in getting tested is reduced, as some studies showed. Therefore, clinicians should ensure that tested persons understand the limits to the validity and certainty of personal risk test results. As a last point, some attitudes towards predictive testing and early diagnosis vary on a cultural level embedded in national contexts. We found a greater openness, for instance, to suicide among German participants, as well as a greater skepticism about test validity and a greater emphasis on personal autonomy in Germany. So we need more cross-cultural comparisons to see whether more general cultural patterns can explain these national level differences. Thank you very much for your attention.